All right, hello everybody. My name is Chelsea Samancic. I'm a physical therapist with Health for Life Naturopathic Medicine, located in North Phoenix, Arizona. So today we're going to take a deep dive into one of the most important and also at times controversial topics in rehab involving the muscle group, the hip flexors. Specifically, we'll be looking at three muscles that make up the iliopsoas complex. These are psoas major, iliacus, and the often overlooked psoas minor. So we're going to cover their anatomy in a bit of detail to start off. At the end, we'll finish with some dynamic stretching and exercise options to help you stretch and mobilize these muscles on your own at home. So we'll get started with anatomy. We're going to start with psoas major. So this muscle is the largest and deepest of the three. It is a long, thick muscle. It originates from the bodies of the transverse process of the lumbar spine, typically from about the 12th thoracic vertebrae all the way down through 5th lumbar vertebrae, as well as from the intervertebral discs between them. Okay. From this origin, that muscle then will descend through the pelvis and it inserts onto the lesser trochanter of the femur, which is your hip. The psoas major is innervated by direct branches of the lumbar plexus, primarily from L2, L3 nerve roots, but sometimes L1 or L4. Its main action is hip flexion, so bringing your thigh towards your trunk. It can also play a role in lateral hip flexion of the lumbar spine when your legs are fixed in place. But as such, so when you're sitting, it acts to flex the vertebral column forward. So some things to understand, because the psoas major originates directly from the lumbar spine, it does have a direct mechanical relationship with your lower back. So this is a key point that we'll discuss here today. Looking at the iliacus, this is a broad fan-shaped muscle. It lines the inside of your pelvis. So the iliacus originates from the iliac fossa. It's a large, smooth, concave surface on the inner aspect of the ilium or hip bone. So as the iliacus descends, its fibers converge and blend with the fibers of the psoas major. So historically, it was always taught that these two muscles share a common tendon, iliopsoas. That inserts then together on the lesser trochanter. So this distinction does matter because it means the iliacus may have a greater capacity to generate hip flexion force than previously appreciated. So when these two muscles were modeled as a single unit. Looking at our third muscle here, we've got psoas minor. So it's the third and least discussed member of the group. And an interesting fact here is not everybody has them. So they've identified in cadaver studies that a significant amount of the population do not have this muscle. But when present, the psoas minor is a small, slender muscle. It lies directly in front of psoas major. Its main action is weak flexion of the lumbar spine and stabilization of the lumbopelvic junction. So we'll put it all together. So to summarize, the psoas major connects the lumbar spine to your femur. The iliacus connects your pelvis to your femur. And the psoas minor connects your lower thoracic and upper lumbar spine to your pelvis and the fascia overlying the other two muscles. So together with that, this muscle group here is often at risk of tightness. So we can talk about who is most likely to develop tight or dysfunctional hip flexors and why. So an example are those that are prone to prolonged sitting. So the number one contributor to hip flexor tightness in modern life is prolonged sitting. When you sit, your hips are held in a flexed position, typically around 80, 90 degrees. In this position, the iliopsoas is in a shortened state for hours at a time. So who sits the most, right? Think about office workers, truck drivers, long haul pilots, programmers, students, so young population, students. They're not exactly set up for success mechanically, well, knowing that they're sitting in a chair for about 6 to 8 hours a day and then going home and studying for a few more hours. But also looking further, anyone with a desk-bound profession. So if your job keeps you seated for majority of the day, your hip flexors are likely adapting to that shortened position. Not just the sedentary or the desk bound, but specific sports are prone also to shortened hip flexors or injuries. In fact, so certain sports that have, high repetitive demand, such as cyclists, they spend hours in a hip flex position. Runners, especially sprinters, they generate massive forces through the iliopsoas with every stride. And then you've got soccer players or martial artists and dancers. They all rely heavily on powerful repetitive hip flexion. We've got other at-risk populations too. So we look at pregnancy and postpartum individuals. Those with pelvic alignments and increased anterior tilt can load the hip flexors differently. This is often short-term. However, having better knowledge of how to support yourself through those stages and even postpartum is really important for that population. Okay, so now we're going to look a little deeper at lumbar spine and sacroiliac joint connection. This is where things can be pretty important, and again, sometimes controversial, but let's talk about how tight hip flexors affect your lower back and SI joint. So remember, so the psoas major originates directly from the lumbar vertebrae. When this muscle becomes chronically shortened, so this is over a long period of time, and it's tight, it exerts a constant anterior pull or forward pull on the lumbar spine. This can increase lumbar lordosis. So that's the curvature that you see in the lower lumbar spine. It's an inward curve of your lower back, and it tilts the pelvis forward into what we call anterior pelvic tilt. The hip flexor muscles are major contributors to lumbar spine stability. When they're tight, they can alter the biomechanics of the entire lumbopelvic region, potentially contributing to disc compression, facet loading, and muscle imbalance. Chain of compensations that can happen when a lumbar lordosis is lost. So you can see how this individual has had a lumbar fusion, well, really a whole spine fusion, but it has affected the lordotic curve. And in response, there's a number of other compensations that have taken place in order to maintain upright posture. So this is a somewhat severe case, but because the spine is anchored and there's a loss of that curve, you can see compensations from the very top in the cervical spine all the way down to pelvis, knees, and ankle. So you can see, just these little adjustments that take place, but it can have a huge effect on mechanical loading. And for some, it does reproduce pain. It's not always an indicator that because this patient has these adaptations that they're hurting, but we can see patterns in our patient populations that with long-term changes and altered biomechanics, it can lead to episodes of care or pain. So we're going to look at the sacroiliac joint, otherwise known as SI joint. So the SI joint connects the sacrum to the ilium on each side. So it's a joint that transmits forces from the upper body and the lower extremities. So it relies heavily on the surrounding musculature for stability. The pelvis is essentially the lowest vertebral level. It's a ring that links the lower extremity to the spine. A stiff or painful hip can transfer stress across this ring to the spine and SI joint and vice versa. So this concept, often known as the hip spine syndrome, reminds us, the hip is connected to the pelvis to the SI, and the lumbar spine. They are all integrated within the kinetic chain. You can't address one without looking and considering the others. Okay, so big concepts here to consider. We started our discussion talking about anatomy of the hip flexor complex, and then we shifted into, okay, well, what does that mean? How can that affect us on a larger scale when looking at the interconnection between lower back alignment, pelvic stability, and posture and function. So what I want to dive into next are exercises and self-mobilizations. Exercise 1, we have a half kneeling hip flexor stretch. We're going to see yourself kneeling on one knee with the opposite foot flat on the floor in front of you. Both knees are at about 90 degrees. You're going to keep your torso upright and your core engaged. This is an important part of that because, again, we want to encourage a little bit of a posterior pelvic tilt with these hip flexor stretches in order to lengthen across the front of your hip and pelvis. So you're going to then gently shift your weight forward. So drive your front knee over your toes while keeping your back upright. You should feel a stretch in the front of your hip on the kneeling side. So once you get that stretch, moderate stretch, hold for about 20 to 30 seconds. And again, you're going to repeat this about 2 to 4 times on each side. Now, speaking to that pelvic tilt, avoid arching your lower back. So the stretch should come from hip extension. That means your thigh should progress behind you and not come from movement or arching of your lower spine. Okay. Another exercise is the supine hip flexor stretch. So this is in Thomas test position. It uses the same position as a clinical test that we use to assess for hip flexor tightness. So if you've seen a physical therapist or an orthopedic, they may take you through this test and be able to help guide you also, but that's a familiar position. To get yourself set up, you're going to sit at the edge of a firm table or a high bed. You'll lie back while pulling both knees towards your chest. Then slowly lower one leg off the edge of the table, letting it hang free. So keeping the opposite knee pulled to your chest will help to stabilize your pelvis. It'll flatten your lower back. And so from there, you just let gravity do the work. You should feel a deep stretch in the front of the hanging hip and hold for about 20 to 30 seconds. And then repeat again about 2 to 4 times per side. Okay. This one's really great. It isolates the hip flexors while stabilizing the pelvis, whereas the half kneel, it does take a higher level of coordination to isolate that movement. We've got another exercise. We've got standing hip flexor stretch. So for those that have a hard time getting to the floor, a standing option can work well. With that, you're going to stand in staggered stance, 1 foot behind you. Bend your front knee, keep your back leg straight. Tuck your pelvis just as in half kneel and gently press your hips forward. So torso does stay upright. And again, you should feel that in the front of your hip. Okay. Now we have prone hip extension. So this is an active stretch. So you would lay face down and lift a single leg. So research has supported that active stretching where you contract opposite muscle group, be it for this, it would be glute max, is equally effective as passive stretching for improving hip extension range of motion. So with that, lie face down on a firm surface, keep your legs straight, slowly lift one leg off the surface by squeezing your glute. Hold at the top for about 5 seconds and then lower down. So perform about 10 to 15 reps for this one per side. Okay. This is great. It not only stretches the hip flexor, but strengthens glute max, so which is a primary hip extensor and is often weak in people with tight hip flexors. So we've got a few more. So we've got self myofascial release with the ball. So there was a randomized control trial in adolescent athletes that found 6 weeks of self myofascial release with foam rolling improved hip flexion, abduction, and hip flexor strength, suggesting combining self myofascial release with stretching may offer complementary benefits. But doing so in isolation is not supported currently with what they have found in current studies. To do it, you would lie face down, place a lacrosse ball or a firm massage ball just below your hip bone and crease of your hip. Gently roll over the ball, explore the area of the iliacus and proximal psoas, and spend about 1 or 2 minutes per side. So follow this one of the stretches described above for best results. So you want to combine it with the others we already went through. And then we've got the couch stretch. So this is an advanced stretch that adds knee flexion component. So it targets rectus femoris in addition to your iliopsoas. So what you'll do, you'll kneel in front of a couch, wall, or a bench. Place the top of your back foot against the surface behind you with your knee on the ground. So from there, you'll bring your front foot forward into a lunge position, tuck your pelvis, and slowly work toward an upright torso. Okay. This is intense, so start gentle, progress over time, and hold for about 20 to 30 seconds, repeating 2 to 3 times per side. All right. So That's the gist of everything here for the most part in our discussion tonight, but I'll leave you with a few practical takeaways. So first, if you sit for a long period of time, set a timer to stand and move about every 30 to 45 minutes. Even brief standing breaks can help prevent this adaptive shortening that comes with prolonged hip flexion. Second, consistency matters more than intensity. So a daily routine of hip flexor stretching, even if just 5 minutes, will produce better long-term results than occasional aggressive stretching with sessions. Third, remember the kinetic chain. So if you have low back pain or sacroiliac joint dysfunction, don't ignore your hip flexors. So if you have hip pain, don't ignore your back. These structures are intimately connected, and addressing one without the other often leads to an incomplete relief. Fourth, combine stretching with strengthening. So tight hip flexors often coexist with weakness in your glutes and core. All right, so a balanced program that stretches the front of the hip while also strengthening the posterior chain and deep core will give you the best results. Finally, if your symptoms persist despite consistent self-care, seek a qualified healthcare provider or physical therapist in your area. Hip flexor tightness can sometimes be a sign of underlying hip joint pathology, lumbar disc disease, or other conditions that may require professional evaluation. So thank you for watching. I hope you found this helpful. Please like, subscribe, and share this video with someone that you think spends too much time sitting. Okay, take care.